It is unethical for medical doctors to prescribe puberty blockers to young people struggling with gender identity issues. Well, today we're going to be talking about the medical ethics of gender-affirming care, and I can't think of two better people to join me in the conversation than Dr. Christina Cirucci, who is a board-certified OB/GYN and who has been actively involved in the pro-life movement, as well as heading up our gender identity team here at Reasons to Believe. And in studio, I'm joined by George Haraksin, who is an ethicist and a theologian. So we're going to have a great conversation today about a really important topic. But before we get into today's discussion, just for those people who may not be familiar with either of you, I'd love for you to introduce yourself. Chris has been on the show quite a lot, so she is a frequent guest on the show. But George, this is your first time on Star Cells and God. So maybe, George, we could start with you, then we'll ask Chris to introduce herself.
Yeah, thank you, Fuzz, for the invitation. I get to serve, as you know, as a senior research scholar now at Reasons to Believe. Yeah. And I also am a senior adjunct professor of philosophy and ethics at Azusa Pacific University. I've done that for over 20 years. And as you know, I was a pastor for over 20 years. In fact, you attended the congregation that I pastored, you and Amy. So that's a little bit of my background. So this is a very important topic that I address in classes, but it's really important to address it here.
Yeah. And then, of course, we have Chris joining us via Zoom. So, Chris, introduce yourself. Remind everybody who you are and some of the things that you've been involved in.
Yeah, thank you, Fuzz. It's great to be back. I'm a board-certified OB/GYN physician. I live in Pittsburgh. I was in private practice for 20 years, and now most of my work is concentrated in research and writing and speaking and things like that. And I'm also a scholar with Reasons to Believe, and then more recently a fellow, where I had the great honor of leading the gender identity team, and we did a deep dive into the research and the literature on gender issues. And that's kind of what started all this, and where I ended up writing this paper that we're going to talk about today.
Yeah, and the reason for this conversation, again, which is dealing with the medical ethics of gender-affirming care, is because you wrote an article that was published in a peer-reviewed journal basically making the point that gender-affirming care violates the key tenets of medical ethics. But maybe before we start unpacking that, because this is going to be quite provocative, maybe remind us a little bit about what is gender-affirming care, and how does it contrast with what was traditionally done when people struggled with gender identity issues?
Sure. Great question. Great place to start. So let me just start with kind of normal medical care. Like, you go to your doctor with a headache, and the doctor will evaluate you and examine you, maybe run some tests and try to figure out what's the cause of those headaches. And then typically start with the least invasive treatment, maybe try you on medicine. He's just not going to do brain surgery the next day. So, we think about the importance of diagnosis and evaluation in medical care. So with gender-affirming care for people with gender dysphoria, so gender dysphoria, just in a nutshell, is a situation where people feel an incongruence between their sex, their physical sex, and their innate self. And so the gender affirming care, what that means is that the person goes in to see the physician, and instead of doing an evaluation, instead of looking into the causes and, again, starting with the least invasive treatment, the healthcare professional will affirm the gender that the person wants to be. So if a 10-year-old girl goes to the doctor and says, I'm a boy, instead of looking into what's behind that, the doctor will say, yeah, you are a boy. Here's some testosterone. And so that is in contrast. This all started around 2012, the gender-affirming care model. And that's in contrast to historically, there are people that do suffer from gender dysphoria. And especially in kids and young people, the standard previous, earlier on was what we call watchful waiting. So support and psychotherapy, but also giving them time, because in most kids, actually, most minors, with time, they will become comfortable with their birth sex.
Okay, so what would be the steps in gender-affirming care? So if, a young person goes to the doctor and says, I identify with the opposite sex, what's likely going to happen then in terms of the gender-affirming care model?
Sure. And when we think about gender transition, we typically think of 4 steps. So social transition, puberty blockers if they've not gone through puberty, cross-sex hormones, and surgery. So social transition, and the kid may be doing this before they even see the healthcare professional, but social transition is dressing like the opposite sex, using the name, pronouns, etc., of the sex gender they want to be. That's social transition. And then the second step, so to speak, is puberty blockers. So if a young person has not yet gone through puberty, they're given a medicine, usually a medicine called, in this country, leuprolide acetate or Lupron, to halt the normal process of puberty, to block puberty. Then step 3 would be cross-sex hormones. So taking the hormones of the opposite sex. A girl would take testosterone to appear more like a boy. A boy would take estrogen to appear more like a girl. And then the 4th step would be surgery, breast surgery, genital surgery, et cetera. Now, I will say not everyone goes through all those steps, but those are kind of, when we think about the 4 steps, that's in summary what those are.
Yeah, so you said that in 2012, there was kind of a transition in the approach to treating people with gender dysphoria from watchful waiting to this gender-affirming care model. So what was the trigger for this transition in care?
Right. So I mentioned 2012 because that's when WPATH, the World Professional Association for Transgender Health, issued their Standard of Care 7, which is kind of where the gender-affirming care. Now, what triggered all this? Very, probably complicated answer. I mean, around that time, there was much increase in young people, in adolescents, wanting to transition. It was kind of skyrocketed. Historically, gender dysphoria was very, very rare, and typically was in either young boys, 3 to 4-year-old boys who struggled with feeling that they were a girl, or adult men who had lived seemingly a normal life. Think of like Richard Levine or Caitlyn Bruce Jenner. So then all of a sudden, 15 years ago or so, we see this marked rise in adolescents, usually girls, presenting to clinics wanting to transition. And of course, that's a whole other story. But kind of along with that came this gender-affirming care model.
Yeah. Okay, so you've addressed a lot of the scientific and medical concerns with different aspects of gender-affirming care as part of the gender identity model. But recently you had a paper published in a journal. What was the name of the journal? What's that? Okay, yes, thank you. About the medical ethics, and we'll put a link to the journal article in the show notes, but about the medical ethics of gender-affirming care. And I don't know if people fully appreciate that the fact that there are that physicians are taught or trained in a set of medical ethics. And I believe that this is a ethical view known as principlism. Mm-hmm. So maybe, George, could you unpack just a little bit about where's the basis for medical ethics arising from?
Yeah. Well, there's a tradition in what's called normative ethics or even objective ethics to say that there is a good, there is a bad, and then you try to figure out what system of reasoning is best to discover in applied situations such as this one. This would be an applied ethical situation. How do we take that reasoning and apply it to a specific situation? So philosophers, ethicists will talk about different systems of ethics to help us navigate these issues. It could be what's called virtue ethics, focused on character, vices, virtues, in persons and communities. It could be deontological ethics, or what's called duty-based ethics. What are my obligations towards not only myself, but others in the community? We could talk about theological ethics, or sometimes it's called consequentialism, when you may have heard the term utilitarianism, right, trying to benefit the most amount of people for, the greatest good for the greatest amount of people. Now, that can be very debated. There's a long history of talking about these different systems and whether they are isolated systems, can they be integrated? But what principlism does is it takes an approach, you might say a practical approach, rather than just a top-down approach that maybe us philosophers might like to try to do, but it tries to take some basic principles of duties or obligations of how we are to act towards others. And Chris rightly notes 4 basic principles that provide a framework where you try to weigh these different principles and apply it to a specific situation. And Chris, if I'm not mistaken, you went through beneficence, how do I benefit the patient? Non-maleficence, how do I do no harm? This idea of autonomy, that the patient has a right to be informed well, and they can accept or refuse the treatment. There's also the issue of justice, but you mainly, Chris, focus on the first 3, if I remember correctly.
Yes, that is correct.
Yeah. So Chris, a couple of quick questions. When somebody goes through medical school, through medical training, how prevalent is this ethical system? Is it very much integrated into the training that you receive as a physician, or is it something that people talk about and then most physicians just kind of sidestep as they go about their practices?
Yeah, good question. It is integrated. We didn't have an ethics class, as I recall, but certainly throughout training, every doctor knows these principles. I don't know all those detailed models George described, but I know this one because we are very clear that we have to, as physicians, we must act ethically. And so for us, it's just boiled down to these principles. And I think that really keeps us in a good place if we follow these.
Yeah. And so you're not an ethicist, but yet you took on this ethical concern in the paper. So why was that? What motivated you to write the paper? Right.
Well, you're exactly right. I'm not an ethicist, but I'm a physician and I must act ethically. And I'm also a researcher. And so I read a lot of articles and I know what I've come to understand how to read them and what they're really showing. But I think also beyond that, I led this, our gender team with Reasons to Believe, and we did a deep dive into all this research and all these topics in all areas. And we had a whole section on ethics, and I did work with, we had an ethics person on our team. But so what I did is really, as I looked at the research for social transition, puberty blockers, cross-sex hormones, and surgery, it became very clear that these are not ethical. So, I'm also a Christian, and that guides my life. But I'm not even looking at this from a Christian worldview. I am looking at this from a scientific and, based on these 4 principles of ethics. So, and what happened is then, I guess this paper, we did the research for Reasons to Believe, and then I had that wonderful opportunity to give a talk on the ethics of gender-affirming care at the ETS conference. And so then I thought, well, I'm going to try to publish this.
Yeah. Yeah. Well, I'm glad you did. How has the article been received up to this point? Have you had any feedback? That may be an unfair question, but.
Right. Well, I will say I submitted it first to a major ethics journal, and it got quickly rejected. A lot of journals may not take this viewpoint very well. But actually, interestingly, I don't know the number of reads or all that. I don't have that on the top of my head. But interestingly, you give your contact information, and I've gotten some emails from people and some opportunities to talk to people and to speak. And so some interesting interactions as a result of this.
Yeah. Okay, so maybe we could step through the paper and just could evaluate, to hear your argument. I'm sorry, because basically the conclusion is that gender-affirming care is violating the principles of medical ethics. So the first principle is beneficence. So how did you evaluate the gender-affirming care in light of that principle?
Yes. So beneficence, like benefit, beneficence means do good. So as a physician, I must not give a treatment to a patient that doesn't have benefit. And we'll frame that in light of the other principles also. But so the question then scientifically and medically becomes, are these treatments beneficial? Have studies shown that there are benefits to social transition, to puberty blockers, to cross-sex hormones, to surgery? And there's not. There's a plethora of studies on this. Now, I'd like to just review a little bit the Dutch protocol that we've talked about, because that was the seminal research on this, and the research from where this all started. And then there's not been any replication of that, and there's not been any, further studies really proving any benefit. But in the Dutch protocol, so this started 2011, some researchers and clinicians said, we have these kids with gender dysphoria. Maybe if we block their puberty and see how they do. And so in 2011, the first study was published. There's two major articles, one in 2011, one in 2014. We block puberty, and then we follow them over 2 years and see how these kids do. And so when they did this and they followed them at 2 years, they did find that there was some improvement in behavior and depression and general functioning. And interestingly, there was no help in their gender dysphoria or other things like anxiety or anger. So then in 2014, they published their second study where they followed these kids out to longer. They followed them at right before cross-sex hormones, right before puberty blockers, right before cross-sex hormones, and before and after sex reassignment surgery. So I may have misdescribed that. It's at every stage they evaluated them. And well, they found out that these kids, their gender dysphoria was better, and they had psychologically developed into well-functioning adults. And that's where this all started. So I'd like to, if it's okay, to get into some of the issues with this study. And
because it sure seems like there's a benefit then, right, to administering puberty blockers, at least based on the Dutch protocol.
Right. And so this all started, and then that's where puberty blockers started. Well, so first of all, these kids there was no control group. Okay, so you normally you give, if you're doing a test in a drug, you give the drug to this group, you give this placebo to another group. There was no control group, so we don't know how these kids would have done if they had nothing, if they had no treatment. But also, they had 2 treatments. They all got psychotherapy. So if they did have benefit, which helped? Was it the transition, or was it the psychotherapy? So that's one issue. And a second issue was that these are not the same. These kids in the Dutch study are not the same, in the same situation and type of kids that are being transitioned today. So the young people in the Dutch study, they had gender dysphoria since childhood, not rapid onset gender dysphoria. They had to live in a supportive environment, which is not always the case. They had to have no comorbid psychiatric problems. So we're already looking at a different population. And if we apply what was done in the Dutch study to today, it's a different population. And the other thing is that, interestingly, I just realized this about this study, is that it's a biased population, because if a kid didn't go on puberty blockers, they weren't included in the study. So we're already excluding a certain population. Well, it gets a lot worse, because what happened is that in the 2014 study, so in the 2011 study, there were 70 kids. So it's a small study. In 2011, they reported on 55 kids. And what happened? Well, some of the 15 that weren't included. So we already have, first of all, that's a 20% dropout rate. That should raise red flags. But what happened to those 15? Well, a couple of them weren't candidates for the surgery because they had developed such comorbid conditions because of the treatment. And some people dropped out, but most concerning, one young person died during as a result of the surgery, as a complication of a young boy who was having a vaginoplasty died. And so we have 1 in 70 who died. This is young people. So another issue with the study is how they compared the results. So they used this gender dysphoria, the Utrecht gender dysphoria scale. And so in the beginning, they gave them the scale for the birth sex, and then later they switched it. So they gave the scale for their transition sex. So they're not really even comparing apples to oranges. So, if this was just a pilot study, and then there were more studies showing, but there's not been replicated. And, we don't have time to go into the hundreds of studies or so that have been done, but we did do that with our group with the research. And, unfortunately there's a lot of studies out there, but they're not showing benefit. And so that's the first principle. You must give a treatment that has known benefit. And we don't have any reason. This is not to say that one person might not benefit or a person might not feel better. But overall, if you look at the data, there is no benefit to these treatments.
Yeah. George, is there anything you want to
let me just pull 2 quotes from you, Chris, if I may, that struck me. You said that these 2 studies form the foundation for today's gender transition, yet the patients in these studies were of a different population, as you mentioned, than most gender dysphoric young people today. And then you said, we cannot say from these studies that puberty blockers, cross-sex hormones, and surgery have any health benefit for adolescents. And I just kind of wrote, wow. It seems like is it really just coming from these 2 studies, I think people might say, and we really can't find little to any benefit? That's really concerning.
It is very concerning.
And then you mentioned this quote from the American College of Pediatricians. Well, maybe we should talk about sometimes the issue of suicide comes up, and you mentioned this in the article, and that really is an emotional pull, because we don't want people obviously moving towards suicidal ideation or even acting upon that. Talk a little bit about that situation and how it's used.
Yeah, and this is just heart-wrenching. We hear this frequently, that a parent is told, well, do you want a live daughter or a dead son? Well, what's a parent to do with that? I mean, they're already see their child in distress, they're trying to get them help, and then they're basically told, well, if you don't let your kid transition, they're going to kill themselves. Well, if you look at the data, that's not backed up by the data. So first of all, I will say that kids with gender dysphoria, they do have a baseline higher rate of mental health issues. They have a higher history of traumatic events and bullying and sexual abuse and autism and depression and such things. So we know that transgender kids do have a higher risk of suicide. We also know that these conditions, carry a higher risk of suicide. But what has not been shown is that transitioning improves that. So one of the longest, there's not a lot of long-term studies in this area, but one of the long-term studies we do have, was done in adults. This was so it's not in kids, but it was a study by the GYN in 2011. They looked at people who had transitioned, and they looked to follow them for 30 years. So it was a study where they matched each subject to 10 controls of their birth sex, 10 controls of their transition sex, and they followed them. And they actually found out that those who went through the surgery, sex reassignment surgery, had 19 times risk of suicide. We have some other studies that show this. And so there's no indication that these transition will prevent suicide. I mean, we know these kids are struggling, and we know they do have a higher risk of suicide. Is transition the answer? There's nothing to say that there is. The data show otherwise, the opposite.
Yeah.
And I should point out, or maybe we should have said at the beginning, just because we're doing, and Krista did a critical evaluation of the evidence, the whole evaluation is meant to have compassion towards those who are struggling with these issues, and to treat them with dignity, employing grace, without denying the truth of what we're seeing. So we don't want to come off as uncompassionate here, but actually overflowing with compassion and grace in this situation.
Right.
I think that's the posture.
Yeah, well, I mean, to build off that point, George, I mean, if gender-affirming care is violating medical ethics, and the first principle is beneficence, it's not a very loving thing to allow somebody to enter into that particular care regimen if you know that there's not going to be a positive benefit from that.
Mm-hmm. I'm wondering, when we say beneficence, helping do the good for the person, do doctors struggle in this situation on defining the good? What is good? Is there a debate in regards to that? Because you said at the beginning that this now is the dominant model as compared to the historic model, which is watchful waiting. And I would assume that the watchful waiting isn't a passive posture, but it is an active posture with, engaging the patient with some other, like you said, non-invasive opportunities. And I'm just curious, how did this become the dominant model here? And do the doctors debate over what they term as the good in this particular scenario?
So you're talking specifically in gender
Yes.
gender care? Well, I mean, this is such a politicized issue and polarized, maybe is better term. And so there are, I would say, on one side, people that feel that this is what you must do, and that feel that if they don't give gender affirming care, this is not doing the good they could do. And of course, myself and others would feel that, and again, it's not just feeling, it's looking at the evidence, that this isn't beneficial. This does do harm. This isn't the right thing. And so, it's we all know it's a very polarized issue.
At the end of the beneficence section, you quote from the American College of Pediatricians, and they said that, quote, there is not a single long-term study to demonstrate the safety or efficacy of puberty blockers, cross-sex hormones, and surgeries for transgender-believing youth. This means that youth transition is experimental, and therefore parents cannot provide informed consent, nor can minors provide assent for these interventions. Moreover, the best long-term evidence we have among adults shows that medical intervention fails to reduce suicide, as you just mentioned, to end the quote. And that's a powerful statement coming from a group of does that carry a lot of weight in the community?
Well, that is the American College of Pediatricians, which is distinguished from the American Academy of Pediatrics. So I will give the corollary. There is, as an OBGYN, there's the American College of Obstetricians and Gynecologists, which is very pro-abortion. And then I'm involved with the American Association of Pro-Life OBGYNs, which is very pro-life. And so in the same way, in the pediatrics world, the American Academy of Pediatrics takes a very view of, gender affirming care is a must for these kids. And the American Academy of Pediatrics, and I know many people in that organization, are really taking the view that I do, or I'm taking their view, and that this is not appropriate, and that this is not beneficial, that we are harming children. This is harming children. And so there is that polarity that we talked about.
This might be a good point to bring up this question before we move on to the non-maleficence aspect of medical ethics. But before we started recording for this episode, George raised a really interesting question. So I'm going to steal your question, George, but I'm giving you credit for it. You're bringing up the fact that there are really there are these two pediatrics organizations that really have very different worldviews when it comes to gender-affirming care or just pro-life issues in general. So, we're basically implying, or maybe even directly stating, that, look, organizations like WPATH really do have almost an ideological motive here behind what they're advocating. It doesn't really seem like, frankly, that they're putting care of the patient at the forefront. They really are, based on what the evidence says, they really are looking at how do you advance a particular worldview and a particular ideological agenda. But of course, as Christians who hold to a pro-life perspective, aren't we holding to an ideology too? And so how do we know that in this discussion that our ideology isn't influencing the conclusions that we're drawing?
Great question. I mean, I think that's important. And like I said, okay, first of all, everyone has some type of bias, right? We all have our views. We all have our bias. And so, I would say when you tasked me and our team to do this research on gender issues, it was, what does the science say? And so, again, as a Christian, I have a Christian view that God made us male and female, and we're not to transition. But we were doing this research, not even saying, but just putting it aside. What does the research say? If the research says there's benefit, then the research says there's benefit. Now, I may say as a Christian, it's not appropriate, but we were looking, what does the research say? And, we all have biases, but we really, our goal was to put that aside and look at the research. And so that's how we approached it.
George, I stole your point. So is there anything that you would like to contribute there?
Well, I think we can talk about more of this later, but I think this is one thing that is really good about Chris's article and what she goes through is she is trying to do an evidence-based approach and allow that to drive the decisions to some degree. Sure, we come with various presuppositions, our understanding of what the good is, what benefit is, and our model of procuring that or making that happen. But Chris is really looking at the various pieces of evidence, and I think this really comes out strong when we start to look at the nonmaleficence. And part of the claim is that gender-affirming care causes it doesn't give benefits, but it actually causes harm through irreversible interventions and significant medical risks. And maybe, Chris, you can talk about some of these issues. I mean, there's the problem, you pointed to this already, of social transition. I think today, especially young persons, are sort of massaged there with social media and other things. They almost have a Lego view of the human person that we can just put pieces in and out, and we can change our avatar online, and we can manipulate our photos. And so there's lots of technology to move us in this direction, even if we don't philosophically have reasoned ourselves there. And we think that social transition is this easy thing, but you discover that it is not. Chris points this out, and then you talk about the problem of puberty blockers, off-label use, and then gender reassignment surgery. So I should hand that part over to you to talk about, because this is where it really gets into the evidence and whether or not harm is taking place.
Yeah.
Right. So non-maleficence, we always say in medicine, do no harm. I can't always help someone, but I must not do harm. And I will couch this to say that we know there are risks to any procedure. There are adverse effects. If someone's going through chemotherapy to cure their cancer, they're going to have maybe nausea and lose their hair and maybe have a risk of something serious. But you have to look at the risk-benefit ratio, obviously. So anyway, non-maleficence, do no harm. And if we look at each of the four things, now social transition is usually not the medical professional doing it. It's the young person, but social transition. So it's not just wearing the clothes and taking the name, but it's a little more invasive things, like a girl who wants to be a boy will bind her breasts tightly. And this isn't just wearing a sports bra. It's like really tight binding. And now again, we don't have a lot of data. We don't have any, peer review or randomized trials or anything like this on this, but most studies on this do show that most of the girls that do this, they have some side effects like back pain and shortness of breath. And so this is not without sequelae. And then with boys, so a boy who wants to be a girl, wants to appear like a girl, is going to dress in girls' clothes, take a girl's name, probably put packing in his chest to appear like he has breasts. But the other disturbing thing he may do is what's called tucking. So this is tucking the penis and the testicles, which you can imagine sounds very awkward and painful and difficult. But we have reason to believe that doing that affects sperm production. So these are not, even social transition is not without harm. I would say the other problem with social transition is, it sounds reversible, right? Dress like a boy, girl dresses like a boy, and she decides it's not the route for her, she can change back. Well, it's logistically reversible. But imagine a young person. I have a friend who works in a school, and she mentioned this kindergartner who was like, nobody knew, I don't know if it was a boy or a girl, but nobody knew she was a boy. She presented as a girl. And so imagine going to school as a certain sex and nobody knows you're not. And then you all of a sudden change. Like, how hard can that be? So there's that issue. And then there's also the issue of it just sets you on a path. I mean, Miriam Grossman in her book, Lost in Trans Nation, I believe is the name, says social transition it's a gateway drug. It sends them on a path. So non-maleficents do no harm. So even the least invasive of these four, social transition, we have reason to think there is harm from that.
But, to me as a biochemist, the idea of administering puberty blockers when a young person is actively going through puberty just intuitively just seems like a really bad idea, and not to mention administering cross-sex hormones. Hormones are things you don't want to play around with because of the wide-ranging impact that they can have,
right.
On the physiology when you are an adult, let alone when you're actively going through the process of puberty. So maybe comment on the harm that puberty blockers and cross-sex hormones cause if you give them to children going through puberty.
Sure. So the way puberty blockers are given in this model, according to the WPATH recent guidelines, is just at the start of puberty. So, this is 8 to 9 years old in girls and 10 and 11 in boys. So just at the start of puberty, give the puberty blocker. So what this blocker does is it stops the release of their innate hormones. So in a young girl, she's starting to go through puberty. Her body's producing estrogen to produce her secondary sexual characteristics. And this blocks the estrogen. And the same in a boy, it would block the testosterone. So now what are the harm from this? Well, there's several. First of all, at this young age, these kids their bone structure is developing. This is the time of, the major time of bone growth. And so there is a risk of osteoporosis. Now, this can be reversed somewhat when they receive the cross-sex hormones, but it's not really clear down the road, what that harm is. So there's that. There's also concern for cognitive and brain function effects. There's also, as you can imagine, so these the concerns with sexual function and fertility, sterility. So these puberty blockers are basically freezing the gonads, the ovaries or testes, in their immature state. And so, these kids may never have normal sexual function, and then and especially when you then give cross-sex hormones on top of it.
So in effect, you're rendering these kids basically sterile.
Yes. They are supposed to be told to freeze their, sperm or ovaries, and a very small percentage of kids do that, like 3 to 7%. As you can imagine, if you're a kid that is struggling with this and the last thing on your mind is having kids 20 years later. So and then these kids later find out they'll never have children.
Yeah. You mentioned not only the social transition, puberty blockers, cross-sex hormones, but then, and I don't know how much we want to get into this because it gets very detailed, and there's some emotion that's involved with this, the gender reassignment surgery, and you mentioned that this may be the most egregious pathway. Why those terms? I mean, I have a sense in reading the article, but maybe just for our discussion, why is it the most egregious pathway?
Sure. And we can go, I don't know if you want me to talk about the cross-sex hormones. We kind of mentioned those a little bit, but,
Sure.
So the kid takes the puberty blockers, or if someone's older than puberty, they've already gone through puberty, they're not going to take puberty blockers, but there are what's called the cross-sex hormones. So a girl takes testosterone, develops facial hair, a deep voice, but she's also at risk for stroke, heart disease, lipid abnormalities, liver abnormalities. These are not without harm. And then a boy who wants to appear like a girl taking estrogen, at risk for clots and stroke and breast cancer and erectile dysfunction, et cetera. So there are harms to those. And then, as you said, the most egregious is the sex reassignment surgery. So, it is graphic, and sometimes I feel like we have to not hide that because I think that truth is important. But so a girl who wants to appear like a boy, the most common surgery is they call it top surgery. They don't call it mastectomy. It's a double mastectomy, removing breasts in a young girl. And then later they regret this. They will never, ever be able to breastfeed. So there is that. And then if that person goes on, if a young girl goes on to have the genital surgery, this is removing her uterus and her ovaries. This is constructing a penis-like structure and testicles. So removing the uterus and ovaries, this young girl will never bear children. Removing ovaries, we don't remove, if I'm doing a hysterectomy because of, say, bleeding on a 35-year-old, I don't remove her ovaries. They're producing estrogen. She needs that. You remove her ovaries, you put her at risk for increased mortality, heart disease, osteoporosis, and so many things. You know, the way God made us is a good thing. And anyway, you're removing her ovaries, her uterus, and then the if she has it's called a phalloplasty, you know, making a penis-like structure. I mean, this is a very involved surgery and usually several stages, and the complication rate is very, very high. A lot of urinary complications. You know, any surgery has complications. When I do surgery, I always tell a patient, you know, there is a risk of XYZ. But when you have a 70% chance of complications, this is getting in a range that is not normal. And then you have a boy who wants to appear like a girl, may have breast implants. And so then he's going to have his penis and testicles removed and then a vagina-like structure created. Now, you know, the most common way to do that is called, this is going to make you squirm, but it's called a penile inversion vaginoplasty, using that tissue to make a vagina-like pouch. And if the boy had puberty blockers, there's not enough tissue there. And so they have to do another procedure where they use the intestine. This is the procedure where the young child in the Dutch protocol died because of infection. So these are wrought with complications just from the surgery. Just to get through the surgery, there's a high complication rate. But also these are clearly permanently disfiguring. These kids will never, you know, have children, never. It's just lots of harm.
Yeah, that to me, when you start describing, even in general terms, the gender reassignment surgery, it is just horrifying. It sounds more like the stuff you see from the island of Dr. Moreau, not something you would expect medical doctors to do.
I want to point out maybe a philosophical issue with the argument itself, and to get your response to this. I think you do a great job in presenting the evidence here. This is very moving, I would say, and even when you get to the graphic portion, you know, there's a lot of emotion attached to that. And Fuzz and I were just talking about, Fuzz, you were saying how there's a sense of losing patience with, you know, these experimental type treatments. I do read in some of the literature, I hear these arguments that, especially for the beneficence and nonmaleficence, that, well, as we progress in our technology, our medical technology, we may or we can overcome these harms and increase the benefits. So one of the limitations of the argument could be that those who hold a different view will say, well, we just got to keep developing the technology better. Yes, maybe we need to roll back what we're doing, be more cautious, but we can get there. What would you say to that line of reasoning?
We don't do experimental treatment. If I guess to approach it that way, and I don't agree with this, but the only way to do that would be in a research context, in a scientific clinical trial with informed consent. Now, you don't do things in kids typically in medicine until you've proven them in adults. But as the American College of Pediatricians said, I mean, this is experimental treatment. And you wouldn't even do a trial unless you had some reason to think there's benefit. So we don't even have that, I'm not going to go, let's do a trial and, give arsenic to everybody, see if it helps. I mean, you have to have some reason that there's a benefit before you even do the trial. So I would really back off on that. And I think that's just, as a physician, this is sounding like Tuskegee experiments. And this is where these are people, we have to be better than that and treat people better than that.
Yeah, I think that's where, I think you put it well, that's where the evidence comes out and says that we don't have the evidence to pursue that path. We don't do experiments on kids. And that would be a very, we've already seen this in the past, as you mentioned, the Tuskegee incident, where science has been used to do harm. And it was horrifying, and we need to go there, as you say.
Right. So, you bring up the whole question of informed consent. So talk a little bit about that aspect of it, because, you make the point really that young children can't offer informed consent, or maybe if you said, look, this gender reassignment surgery is completely experimental. We just want you to understand that. Is that something that's acceptable then? If people do grant, consent to do those kinds of procedures, does that overcome the nonmaleficence and the benefit that, or the absence of benefit?
No, it doesn't overcome that. And there's a lot of issues with informed consent here. So now we're moving on to that third principle of the four, which is autonomy. Patient autonomy means that a patient can, choose to receive treatment or not receive treatment. What it doesn't mean is that they can just have anything they want. It's not a drive-through. I can't, but big part of autonomy, a patient, their ability, their right to choose, accept or refuse treatment, is understanding that treatment. So they need to be advised of what their diagnosis and their condition is. They need to be advised of the treatment options. As a physician, I would say, this is what I recommend. These are alternatives. And I would explain also the risks, advantages, and disadvantages, not only of the treatment I'm recommending, but of alternative treatments. And another important part of informed consent is that the patient must be competent. So, a couple issues here. So they're not informed of all this. One of the treatment options for gender dysphoria is no treatment. And, when a kid goes into a gender clinic and says, I'm a boy or I'm a girl, and after 2 hours walks out with a prescription for hormones, this isn't informed consent. And the other thing is that for a doctor to obtain informed consent from a patient, as I said, they have to have a diagnosis. So there actually needs to be an evaluation. What if the kid their problem is depression, not true gender dysphoria? What if it's bullying and sexual abuse? And so it's very complicated there. And the other issue, the competence, is a child competent to consent to these treatments? No. In fact, kids can't drive till they're 16. They can't vote till they're 18 and drink alcohol till they're 21. And yet a 9-year-old girl can consent to having her breasts and her uterus removed. The WPATH guidelines say that parental consent is preferred but not required. This is very disturbing.
Yeah, it is. It's interesting because, George and I have worked on a book together called The Age of Playing God, and one of the chapters involves xenotransplantation, where people are, exploring the use of pig organs as bridge for organ transplants, maybe as permanent organs for transplant. And there's such a significant amount of debate around informed consent, even to the point where people are arguing that a patient who is terminal, who knows they're going to die, who's in desperate straits, may agree to these procedures simply out of desperation. And the question is raised, is that genuinely informed consent because the patient is in such a desperate situation? So these are adult people that have lived long lives, who have a lot of experience, and there's concern about, is this bona fide informed consent? Because of they're in a desperate situation, yet there's not the equivalent debate going on here about a 9-year-old agreeing to receiving puberty blockers. That to me is just a stark inconsistency, and almost feels like hypocrisy to me, frankly.
Yeah.
I think also for me, when you were talking about autonomy, I actually think I understand why you didn't go to the justice issue, or maybe you can clarify that. But I think you can link that, go even further to the justice issue about if justice is treating people equally. But it's also about treating unequals unequally, in the sense of, if you don't have certain cognitive abilities or experiences to understand or to imagine the future, how does a pre-adolescent or a pre-puberty person really conceive of whether it's sex or having children, and how can they be have informed consent on these issues if they're not cognitively able to really engage with those? Would you comment on that?
So I want you to I got lost. I do have some comments about the justice, because I've rethought the justice issue, but
Yeah, go ahead.
Give me your question again, or you want me to go down the justice route?
Go down the justice route. Want to hear?
Okay, so in this paper, I talk about 3 of the 4 principles, and I really just, it's kind of painful to write paper and only touch on 3 out of 4, but I just couldn't find a place where I just didn't see how justice was violated. So justice is, giving fair and equitable treatment. So as a physician, I need to treat a poor patient the same as I treat a rich patient, for example. So, but since then, in fact, it was after I read the United States report by the Health and Human Services, because they talk about justice, I believe justice is violated here, because what's happening in gender-affirming care is those with gender dysphoria are being treated differently. If I have a headache and go to my doctor, I get an evaluation. If I have gender dysphoria, I don't get an evaluation. So this is not justice. They're not being treated with the same medical rigor and evaluation as people with other conditions. So I've kind of I wish I would have understood that maybe when I published this paper, but I do think justice is violated.
Yeah, I came to that same conclusion while reading it. You also, are you familiar with the Cass review?
Yes, absolutely.
Oh, okay. I don't think you mention it in here, but it's interesting that from the British National Health Service, the UK pediatrician Hilary Cass, they did a review in 2024 interviewing patients and physicians, and they seem to come to the same conclusions as you did. In fact, she even critiqued U.S. physicians, or the posture that we're taking. And because of that, I went through a list to check this out. The European posture has changed. Finland now advocates psychotherapy. Sweden only allows hormone treatments for exceptional cases. Norway has gender-affirming treatments labeled as experimental. And Denmark limits treatments to adolescents who experienced gender dysphoria only since early childhood. So the evidence seems to be piling in that in sort of the position that you take.
Yes, the many other countries besides the U.S. a few years ago changed course and realizing what we're talking about here, that there is no evidence. In fact, a few years ago, there was this eloquent letter to the editor or opinion piece maybe in the Wall Street Journal by many of these researchers and clinicians in these countries, not signed by, I think it was signed by 21, but it was signed by the people that are doing this, that had published some of the research, and they said the evidence isn't there. This is that we need to stop, and psychotherapy should be our first line treatment. And the other interesting thing is you mentioned the CAS review. So that was in the UK. And then more recently, and then we did a podcast on this, the HHS review in our country came to the same conclusions as well.
So speaking of that HHS report, and you and I, Chris, did a program for Star Cells and God where we discussed that report. There is a section in that report about medical ethics. So how does their conclusion compare, contrast with the conclusion you drew in the paper you published?
Yes, they came to the same conclusion. They kind of framed a little differently. I kind of go through 1, 2, 3, and now 4. And they kind of looked at it. I mean, they did go through that, but they also kind of talked about risk-benefit ratio. So, again, there's risks to most treatments, but the benefit must outweigh the risk. And, it's in a woman who has breast cancer who might be cured if you remove her breasts. Well, there's risk to her. You're removing her breasts, but the benefit outweighs the risk. That's not the case in a 10-year-old girl to have her breast removed because she wants to be a boy. And so, well, first of all, there's not the same benefit, and there's even more risk. So they really framed it in the risk benefit, but it was the same evaluation. They came to the same conclusion. And then, as I mentioned, they touched on the justice issue, which was kind of what sparked me to realize there is a justice aspect here.
Yeah. George, is there anything you want to add here before I maybe bring everything to a close?
There's one thing about, I think behind some of this, and this is kind of where I do some of my work, I not only teach philosophy and ethics, but I used to have to go from the classroom and be a pastor and deal with the ground level on where people are struggling, where they're celebrating, and all those things. I wasn't detached from the everyday living situations of people. And I think something that Chris pointed to is that clinicians and that they're not in the ivory tower. They're just not thinking theoretically about these things, but they're thinking right there on the ground where people are feeling, and they have to apply practices and medication to these things. In some cases, that could be irreversible. And we talked about that. I think also, though, behind some of this, we should understand that when we talk about autonomy, there's this idea of freedom. And the historic view for freedom and autonomy was to be free from oppression, but also the positive side of freedom, the freedom to be able to do what I ought to do. So there were certain obligations in that. And today there's really have been a change in how people understand freedom. And I can hear this in the students. I can hear it when they're talking on the lawn at the school. Now freedom tends to lean towards, whether they can articulate it or not, but the freedom to abolish limits. It's the freedom almost from the reality that they experience. And there's a sense of that we talk about the age of playing God, that I'm the captain of the ship. I'm the captain now. And it's really that, well, I exist and I need to create who I am, whereas the Christian view is I'm created in the image of God. I have an essence. I have an identity in God. And then I need to live my life according to that identity, that givenness. So there's a sacredness to soul and body, and I need to live that out. And those are competing views. As Chris talked about, some of the competing views in the scientific community, in the medical community. There's kind of philosophical, theological issues here, too, on what we mean by freedom. What do I mean by, am I just exist and then I create myself? Or do I have an essence, an image of God that I live out? And I think those are key things to think through. And Chris, I wish I would have had this paper when I was a pastor. I think it'd do a great service to those who are in the trenches helping people walk through these situations.
Yeah. And that kind of leads us to the final question. And George, I would also be very much interested in your perspective as somebody who has served for a number of years as a pastor. I mean, what are parents to do? What's a young person to do if they really are struggling as a young person with gender identity issues, or your child or grandchild, or people in your community that are struggling with these issues? How do we help them navigate? What are they to do?
Well, Chris can talk about more on the medical side. I mean, I know she's interacted with people like this, but for me, I would simply sit down and let's talk. Just start asking questions, help them verbalize what's going on. And I think when people have just immediate compassion, a level of clarity and understanding of what they're going through, a support of their community, that can go a long way. Mm-hmm. And she mentioned at first about psychotherapy, but there's also how the community helps to heal one another in bearing each other's burdens, the New Testament talks about. So there's a lot of pre-work, if you will, that parents mm-hmm. and church leaders and community leaders can do in this situation before it necessarily maybe gets to the clinical level or the doctor's office. But right now, or at least recently, we've sort of jumped all that, or we're in a difficult community where we don't have that support, and so this is the only answer. But Chris can speak to more of the other side of that.
Yeah, I think what you said is really important, George, and for community, and the church is important. And, the church needs to come alongside these people. And I would point people to our white paper that Ken Keithley wrote on the biblical view and how churches should be welcoming but not affirming. So we want to come beside these people and love them. And then I think from a medical view, so I just want to take a step back here and say, we're talking about the science and what does the study show and is there evidence, and it sounds all very scientific, but you go down to the boots on the ground, and these are people. And so as a physician, I need to know what the evidence shows so I can help take care of people. And so we've talked about that. But these are people who are really struggling. And I would say to a parent, if your kid comes home and says, I'm transgender, well, first of all, continue to love your kid. And it's a long game. You have to play the long game, inform yourself, get informed, but don't immediately go to a gender-affirming doctor or psychologist, because they're just going to go right to that path. And a lot of these kids, most of these kids even have underlying issues. There are girls that have been abused, sexually abused or assaulted. We hear this story again and again, and therefore say, I'm going to be a boy so I don't get hurt anymore. Well, that's not the answer. And so kids who are depressed or a lot of mental health stuff, let's not just say gender transition will solve your problem when it doesn't. Let's look at what's going on. And so, yeah, it is playing the long game, and it is, or not play, I shouldn't use that metaphor, but it is, a long-term thing, and coming alongside and with compassion and love and seeing what's really going on. Because especially with the rapid onset gender dysphoria, These are not the same kids as the boy who's had gender dysphoria since he was 3 years old. That's kind of another topic. These are kids that often it's, affected by social media and peer pressure. And so we have to come alongside these kids and see what's really going on in their lives.
Yeah. And I think the motivation here behind all of the work that you and your team did and that you and others on the team continue to do in this whole arena is ultimately motivated by love and care and concern for, as you said, very real people who bear God's image, who are the object of God's love, that speaking the truth, as painful as it may be, is an extremely loving thing to do, particularly when the path that somebody wants to go down is naively is going to cause them not only not going to deliver a benefit, but it's going to cause them harm.
Yes.
And I think the principles that Chris uses, the Christian worldview grounds those principles very, very well. Love is really to seek God's good in another person's life. What is God's good in your life? The principle of nonmaleficence is, I'm not to do no harm to you. I'm to seek your good. I don't want to violate the sacredness of what God has created. And the idea of autonomy, God has given us free will. He wants us to draw into him by choice and love. And that's a very different posture than coercion or manipulation, and justice too, as Chris mentioned. So all those principles have a fairly well-grounded basis in the Christian tradition and in the nature of God, I would say.
It seems to me that implicit in medical ethics is this view that human life has value and has worth that really is inestimable, because if it wasn't, these medical principles really make no sense. To me, they make no sense in a naturalistic framework, but that's maybe another topic for another day. Chris, any final words before we wrap up?
Yeah, I just want to reiterate what I just said. If someone out there, you or someone in your family and is struggling with this, we just want to say we want to show compassion. We feel for you. We want you to get the right help, and we don't want to dismiss what you're going through, but gender-affirming care is not the answer.
All right. Well, Chris, thank you. George, thank you for being with us. And thank you for watching today's episode of Star Cells and God. We would really love for you to let us know what you think about today's program. So please make use of the comment section. I want to let you know that we read each and every comment, though we oftentimes don't have an opportunity to respond. Also, make sure that you go to our YouTube channel, Reasons to Believe, and subscribe. There you can get notified when the next episode of Star Cells and God drops, which is every Wednesday. You can also listen to Star Cells and God on your favorite podcast app. Make sure you share this program with a friend, and remember that the more we know about science, the more we have reasons to believe in the triune God of the Bible.